Welcome everybody to our Northern Virginia Family Practice's second installment of Be Well Virginia. This is our weekly town hall that we're having for our patients and guests. And we are using this as a way to educate you and communicate with you about the pandemic with COVID and let you know what we know about this and keep you informed as best we can. Thank you everybody for showing up today. Right now, as we said, we have it's already up to 58 participants. That's amazing. Last week we had about 150 on our town hall, and that is just fantastic. We were thrilled and amazed to see everybody on these calls. And it's a testament to all of our patients that you guys are so engaged with us and are willing to learn more and take control of your health and your safety. And so we appreciate that you're doing all this. And we want to help you with that. That's why we're doing this. This is our town hall right now. We're going to keep doing this every week or maybe every other week about COVID to keep you informed of what we know. Hopefully in the future, as long as you remain interested, we can move on to other things eventually, like diabetes, high blood pressure, heart disease, the other things that are still happening. They haven't gone away just because COVID is here. And so we want to address some other health things. I'm sure you're all like us are probably sick of hearing about COVID already. So hopefully we can move on to some other topics in the future, and we'll keep doing this as long as you all are interested and want us to keep doing it. I'm Dr. Ken Zweig. I'm the newest member of Northern Virginia Family Practice. I'm thrilled to be a part of this group. I've been here about 6 months, and it's been an absolutely fabulous opportunity working with great people. I'm really happy to be here. I have about 400 or so patients already, and a lot of you, if you have signed up with me, have not reached out. And so I'd encourage you, if you haven't met with me, if you haven't introduced yourself and made an appointment, please do so. A lot of people are saying that they don't want to bother us because they think we're too busy. It's actually quite the opposite. Most of the physicians, outpatient physicians around the country aren't busy right now because people are staying at home, they're not coming in. And so we've been doing telemedicine visits. They've been working out a lot better than we ever anticipated. I'm amazed at the number of conditions that we can address through telemedicine. It's working very well. And after a couple of months of doing this now, I think we've gotten quite good at it. So I encourage you to please call, make an appointment, introduce yourself, address your chronic care conditions with me, get to know me. If you've signed up with me, I want to meet you before a problem arises. So please make an appointment and introduce yourself so I can know who you are and be able to help you address issues if and when they arise. And what we don't want to do is everyone's so worried about COVID, they're afraid that that we might tell them to come into the office or go to the ER. What we don't want to do is let you sit on problems until they become a real problem, when then you have to emergently go to the emergency room. So then you have an advanced condition that we haven't addressed, and you're putting yourself at risk for COVID when we could have preventatively stopped both from happening earlier on. So please reach out to us. Communication is the hallmark of good medicine. So I want to hear from you. All of us do. We all have time and we want to hear from you. Just a few updates. It looks like, from what we can tell, it's still tentative, but it looks like we are reaching the peak in Virginia for COVID. We think, all the numbers are a little delayed because the tests take some time to come back and to reach the Department of Health, so we know how we're doing, but it looks like we're getting to the peak. So what you're doing is working. Keep it up. We encourage you to keep it up. I know it's tough. It's tough on everybody. It's tough on us, but it's working. And hopefully as we hit this peak, we can start going down the backside soon and start getting on with our lives eventually. But for right now, we need to keep doing what we're doing. And we're nowhere close to the problems they were having in New York and Detroit and in Louisiana. We're doing well. The hospitals here are busy, but they are not overwhelmed. They are able to still maintain good care. And that's what we want to do. We don't want to overwhelm the hospitals when they get to a point where they can't take care of other things. So please keep doing what you're doing. Also, just so you know, we are no longer doing any testing at NVFPA for COVID. We had some tests that we're able to do. We've more or less gone through those, and we aren't able to get new ones. So we cannot do testing at our office. However, there are now 5 testing sites in Northern Virginia. They require physicians order. So if you think that you need to get tested or you qualify for testing, please call us. Again, we want to talk to you, and you need our order for that to happen. Not everybody qualifies, and it's not appropriate for everybody, but if it is, we can talk you through that and get you testing if that's necessary. And on the other side, hot off the presses, we just got something this afternoon that we may be able to start doing antibody testing, possibly in our office. This is sort of unclear. This was literally an email that came in right before this started. So we're still waiting to hear more about it. We don't know how good the test is. We don't know really what it entails, if it's covered, who qualifies, or any of those things. But that's encouraging that is coming through, that we're going to hopefully have that available to us sometime soon. All right, so after that long-winded introduction, we can move on to some other things here. Today, we're going to talk about the GI manifestations of COVID. And for those of you who don't know, that might sound like an odd introduction or an odd topic to cover, since all the press is focusing on the respiratory symptoms of COVID. But there are those of us in medicine realize that many viruses affect the whole body or can affect any organ system. And so it's not uncommon for viruses to go other places. And there's a lot of GI manifestations you can get from COVID. And so we're going to go into that. And in case you're wondering why I'm moderating, we decided to take turns. I drew the short straw today, but because of that, I'm thrilled that that was the case, because it gives me the great opportunity to introduce our two speakers today, or two fabulous physicians that I've had the pleasure to work with and get to know in the last couple of years. First is Dr. Deborah Brauer, who is a gastroenterologist at Digestive Disease Physicians in Alexandria. I believe she's been there about 10 years, 9 years?
That's right, almost 10 years now.
Almost 10 years, okay. So Dr. Brauer went to medical school at Eastern Virginia School of Medicine, and did her residency and fellowship at George Washington University, that you all may have heard of. She, in 2007, was chosen as the Resident of the Year at GW, which is very impressive. And over the last 2 years has been named as a top doc in both Washingtonian and Northern Virginia magazines. And that is a well-deserved honor. And congratulations to you for those awards. One thing I found out recently about Dr. Brauer is that she, an interesting tidbit is that she went to the Junior Olympics for fencing while in college. So that was fascinating, and you probably don't want to challenge her to a duel. And then also we have, from the primary care standpoint, Dr. Natasha Beauvais, our fearless leader here at Northern Virginia Family Practice. Dr. Beauvais, she went to undergrad at Yale University, and then did her medical school at Connecticut School of Medicine, University of Connecticut School of Medicine, did her residency at SUNY Stony Brook. Dr. Beauvais, in addition to being a wonderful physician, is also the president of her practice at Northern Virginia Family Practice, and is raising 4 children at home. So to me, that is pretty much the definition of superhuman. So thank you to both of you for being here. It's been a thrill to get to know both of you. And if any of you patients have been fortunate enough to be the patients of either of these physicians, you should consider yourself very lucky. They're both fabulous physicians. So with that long-winded introduction, why don't we move on to what we wanted to talk about today. So Dr. Brauer, why don't you start and let us know a little bit about the GI manifestations of COVID and what you've been seeing.
Sure. Well, thank you so much for that warm introduction. I appreciate it. Happy to join you guys and inform your patients about what some of the GI manifestations are that we know of COVID. As everyone knows, this is continuing to be an evolving discussion and fact-finding mission as patients are becoming infected, and then we have the chance to be able to study them. So, you know, we think that GI manifestations of people with COVID range anywhere from 30 to 60% of all patients who have who've been infected with coronavirus. The vast majority of those patients actually also have respiratory symptoms. There's only a small percentage, and this range is anywhere from 30 to 20%, that just have GI manifestations alone. And typically the GI manifestations come before the respiratory symptoms, And they usually lag the respiratory symptoms anywhere from 2 to about 7 days. Common symptoms people will have would be abdominal pain, diarrhea, nausea and vomiting, and loss of appetite. So pretty similar to what you would expect from other types of GI illnesses. One of the things I think to look for it to know, is this just an infection with a common GI bug or potentially COVID, would be one, potentially the presence of fever. Typically, infectious GI organisms don't present with fever. And then certainly if you develop the respiratory symptoms, if those begin to occur, you have to start thinking that you might be dealing with a patient with COVID, and those people should get testing if they're sick enough to warrant it.
Great. Thank you for that. So, well, are there any serious complications or serious GI manifestations of COVID that patients should know about, and what should they be looking for?
Sure. So the interesting thing is people who have GI symptoms typically, from the preliminary data, look like they're going to go on to have more mild disease, meaning that they may not require hospitalization, ICU care, even intubation. For people that hit the hospital who are sick enough to warrant evaluation in the emergency room, those people, if they have elevation in their liver enzymes, those people need to be watched very closely, because those are the people that we worry about that may go on to have a more severe disease course.
Is there anything that patients might be able to notice? Obviously, this elevated liver enzymes, they won't know until they
Sure, of course.
Is there anything they can know or see that they may be worried about?
So again, I think that with any GI illness, if you start becoming dehydrated, if you're starting not being able to keep fluids down, those would be indications that, again, you may want to call a provider, especially if you have other comorbid conditions, to see if it might be appropriate for you to go and get some IV hydration. We're going to talk a lot about how people are fearful to reach out to us and reach out to the emergency room to get the care that they may need, and it may prevent them from needing more acute care down the line.
Yeah, so again, we encourage everybody to call if you have any questions or concerns. If you're not sure what to do, please give us a call. And so what we're going to do is try to go through some of the questions that people sent in. It was a good introduction, but we're going to try to get through the questions that we have and, as best we can, get through as many as we can. So some questions that people sent in, they want to know, is COVID transmissible through stool? So
the answer is we think so. It is detectable in the stool, and therefore it is thought that the fecal oral route is, like many other infectious GI diseases, may be a source for transmissibility. The issue is that we don't have great testing available to check for it in the stool. So if it is something that you're worried about, that you may have it, certainly what we would tell people in other types of GI conditions, that you want to isolate yourself to one bathroom. You don't want to share that with people. You want to make sure you're practicing good hand washing, that you're cleaning these surfaces frequently, but we do think that there is possibility that it is transmitted fecally. We just haven't been able to prove it definitively yet.
Sure. And we touched upon this a little bit last week, but one of the questions that people want to know, is there anything special that they should do as far as cleaning the bathroom in anybody who's had COVID?
So luckily, COVID is kind of a wimpy virus, as opposed to some other things that we think about that we have to deal with in the GI world. Luckily, it is kind of wimpy. So making sure that you're using good cleaning products, preferably bleach works very well, making sure you're washing your hands appropriately, cleaning surfaces frequently touched, those are all very important.
Great.
But you don't have to do anything special for it.
Perfect. Yeah, and we talked about that last week, and again, you've probably heard it 1,000 times. We can't reinforce this enough. Washing hands is just vital. Even before COVID came around, we knew that hand washing could prevent 25 to 50% of all infectious diseases, and so now it just becomes even more important. So keep that up as best you can. And one person sent in this question, might seem kind of funny, but I think it's actually probably very relevant and on top of many people's minds, is what to do if they run out of toilet paper.
So toilet paper is, I think, something we're all going to look back on where did the toilet paper go in all of this? And so, when I hear questions like that, we're talking about, well, what else does that mean? Are those people not going to be able to get other things like medicine, food? So even though it's a funny question, it is something you have to think about seriously. And that's when certainly you want to reach out to your neighbors, your community, to see if you can help. If you're in a pinch, what I can tell my patients is we follow the Europeans. We can use a little bidet. You can always go into the shower, wash yourself off, towel off. Or if you have kids at home, baby wipes work great in a pinch.
Absolutely. There's some other interesting suggestions on the internet as well. And what can we do? If somebody has just GI symptoms and they're worried about COVID, what should they do? Yeah,
so the question, again, we do think it's shed in the stool and it can be detected in the stool. The problem is those tests are not readily available and the reliability is questionable. So for us out in the community, the best that we could offer patients would be if they're otherwise having mild symptoms, we ride it out. If you're feeling like you're not doing well or you're having developing of respiratory symptoms, that's when you should go for the standard COVID tested with the nasal swab. In fact, I did have a patient who I was concerned about who really wasn't having respiratory symptoms, and I sent her for nasal swab just because it was the only test that we did have available to make sure she didn't have it.
Great. So if they're having mild symptoms, is there anything that they can do?
So really it's supportive care. It's exactly what we tell people with any sort of GI illness. You want to make sure a light diet, liquids, making sure that if you're having things like fever, making sure you're taking medication to help break that, and watching to make sure you're not going to get dehydrated.
Great, perfect. All right, and so we talked about it a little bit about how this is impacting our practice at Northern Virginia Family Practice. And as I said, COVID's really been impacting just about every physician in the country in the way that they practice medicine. How has it changed how you're practicing, and what have you done to change how you're doing things?
Yeah, it's fascinating. It's a fascinating time to practice medicine. And for someone who's always been, had a passing interest in telemedicine, when we saw where this was going, I really wanted to jump on that platform, and we have. So within the past few weeks, we have converted almost over 90% of our patients to telemedicine. And it sounds very similar to what you guys have done, has worked beautifully. Patients are comfortable, they're safe practicing their social distancing, and they're getting their needs met. And this is particularly good for our patients who are on immunosuppressive medications, of which we have several patients who need care but don't want to risk exposure. So it's a wonderful platform. We're offering it at our office. I think most providers are, and I'm hoping that it's here to stay, because I think patients will hopefully demand it.
Great. Do you want to say anything about the pre-screening visits?
Sure. So as was alluded to, I think some patients are concerned about reaching us out to any physician right now because they think we're being overwhelmed with COVID. And while that's true for the hospitalists, certainly the pulmonologists, the infectious disease doctors, many specialists, including our practice in particular, we are slowing down. We're not doing procedures, is where we spend 50% of our time, so that now we don't have that 50% of time filled. And this is the time where we're hoping that people that need to get either their routine care for to discuss a colonoscopy, either a screening colonoscopy or follow-up colonoscopy, or if they're having issues that they may not have wanted to take off of work, things like reflux or some irritable bowel symptoms, problems with constipation or diarrhea, this is a perfect time to reach out to us, to talk to us about it. These types of appointments can easily be done through telemedicine. And this is the time, because when we eventually open back up, we will have a backlog of procedures, and it might be more difficult, at least in a month or two time frame, to get in to see us, because we're going to have to take care of the patients that we've been waiting on to do procedures on.
So how do you plan to prioritize those patients when things do open back up?
In terms of procedures? So that's a very good question, and it's one that's really hard for, I think, all proceduralists, and certainly gastroenterologists is no exception. We have, it is pretty easy for us to state that people who have no symptoms, who are just coming in for their screening procedures, those people can almost always be safely put off for a couple of months. And we've talked to our patients, and they understand. What becomes is the subacute patients, people that have new onset anemia, people that have abdominal pain that is somewhat chronic. We are doing still some procedures. Those are very individualized based on a strict set of symptoms that we've come up with in our practice, and it certainly is case by case. Probably in the next few weeks, those restrictions are going to be loosened, and we'll start looking at some of those subacute patients that we don't want to put off too much longer, but we didn't want to do at the height of the pandemic.
Great. And what are you doing to keep patients safe who do need procedures?
Mm-hmm. So that's a great question. Certainly, we're having long conversations with those patients about the risks of COVID. We in our facility, as well as Alexandria Hospital, which is also where I do procedures as well, are taking all of the recommended precautions by GI societies. So that would include spacing out patients, making sure we do a deep clean of the room between each procedures. We are wearing the appropriate protective equipment for the proceduralist, so myself as well as the staff, the anesthesiologist, everyone is wearing N95s and the appropriate gowns and gloves. Luckily, we do not have a PPE shortage, which is great. And so patients, we are protecting the patients to the best of our ability, given the situation.
And so how do you weigh the risk of COVID versus the need for procedures in each patient?
Yeah, again, it's very individualized, and that's why, again, it's important to reach out to us. I've encouraged my patients to continue to have a conversation. Every patient who I think might fall into that either acute or subacute category, we have a conversation about what's going on with them, as well as their underlying medical conditions, which might put them at increased risk. But sometimes you do have to do it. I did have one patient who initially we wanted to put off. She wanted to put the procedure off because of COVID, and I thought it was reasonable. She continued to have symptoms. I got more concerned and eventually convinced her to have the procedure, which was good because she did end up having colon cancer and needed to go on to surgery. That patient, if we would have put off, would have ended up in the emergency room and been in a much worse position than if we did it in a controlled environment like our endoscopy unit. So that's a case where it was the right decision to go forward at the time.
Great, good for you. And yeah, that's where the art of medicine comes in.
Right.
Everything is on a case-by-case basis, and it becomes a discussion between us and the patient, and trying to come up with what the risks are, weighing the risk of possibly being exposed to COVID versus the risk of not treating the other condition that doesn't have anything to do with COVID. So
right, and
everybody's dealing with now.
And that decision was made via telemedicine. We were able to do that, so she didn't have to expose herself by repeatedly coming back into the office. So communication is very important.
Absolutely. Yeah, that's great. Well, good. I'm glad that turned out hopefully okay. And then, we have a lot of patients, not nearly as many as you, but with inflammatory bowel disease. Mm-hmm. What could happen if they don't get the routine screening for those conditions?
Yeah, so our patients who have inflammatory bowel disease, which includes Crohn's disease or ulcerative colitis, these patients typically are on immunosuppressive medication. And when COVID started hitting, I probably got 20 to 30 calls from these patients at least about what they should do with their medication because they were nervous about what was going to happen. The recommendation is for people who are on immunosuppressive medication, they should continue this medication because even though there is a slight risk, or there is a risk of them developing COVID, the risk of them coming off their medication and flaring, requiring either emergency room visits, steroids, or surgery, it would be much higher and much more dangerous for them. So that is our society recommendations. I'm not sure about others like rheumatology or other patients that are on immunosuppressive medications, but I suspect it's across the board. That's what we're saying to people.
Great. That's a great point. Yeah. And as we said, unfortunately, even though we're in the midst of a pandemic, other conditions don't take a break, and so they need to be addressed. Mm-hmm. So yeah, that's a really important point. So, all right, great. Is there anything else that you'd like to let our patients know about GI-related issues with COVID or other non-COVID related points?
Sure. I mean, just once again, I think that the GI manifestations of COVID have not been widely televised in the national media, so I think patients may not be as aware of them. I think that certainly if you start to develop GI symptoms, I wouldn't be alarmed, but it should raise some antennas. Certainly if you have respiratory symptoms that develop afterwards, that would be an indication that we might be dealing with coronavirus and that you should practice, or you should contact your physician or your specialist gastroenterologist. Finally, as I think has already been mentioned and probably will be mentioned in the future, don't neglect your other medical conditions. Just because coronavirus is going on, things still can happen. I had one patient call me who had probably a bowel obstruction over the weekend, who most likely needed to be in the hospital with surgery, and she did not call me because she was scared that I was going to tell her she had to go to the hospital. She luckily did okay, but it could have been a very different story. And if we can do it, and we can do it in a controlled environment, we can still take care of you. But if things get out of control, that's when your risk goes up.
Great, yeah. So I think we keep reiterating this point, but just realize, obviously we're very aware and attuned to what's going on. We don't want any of our patients to go to the ER either. We know that is a risk. But if you call us early and if you get in touch with us, we can help to navigate that and decide what the right thing for you to do is. We don't want people to go to the emergency room even under normal circumstances. We try to keep people out of the emergency room as much as possible. It's not a fun place for anybody to be, so especially now. But the earlier you call us, the better we are at helping you to stay out of the ER. Or even, going to the right ER. The point I had the other night, I had somebody call me that certainly needed to go to the emergency room, and I called several ERs to see which one was the least busy, so that they wouldn't be exposing themselves. And, so we can work with you, and but we only can work with you if you call us and you contact us. So good communication is really the key. So great. Thank you so much. I really appreciate that. That was very, very helpful. If you don't mind, we're going to move on to some more general medicine points with COVID and bring Dr. Beauvais into the fray here. So, but thank you very much. That was really helpful. So, Dr. Beauvais, would you like to give us a little update on where we are? I think I mentioned that we are seem to be reaching the peak. Do you want to get, at least in Virginia in general, can you give us a little update on where things are with our local hospitals?
Sure. Well, first, thank you so much, Dr. Brauer. Dr. Brauer has been in the top docs for only 2 years, but she's been a top doc for a long time. She's been taking incredibly good care of my patients. She's just very easy to talk to. She really communicates well, and she's up to date on anything that you need to ask GI. So I really, really have relied heavily on her and on her practice. I'm a patient of someone else at her practice, and I would highly recommend them. And Dr. Zweig, I'm so glad you're here. Been so excited to work with you for the last 6 months. I'm very, very grateful to have you just as a colleague to be sharing ideas with, and thanks for hosting this today.
It's been a lot of fun. Thank you.
Yeah, so the quick version of the hospital update locally is that the numbers are still fairly high. I mean, the hospitals have really low censuses of everyone else right now, but I think when we checked last night, it was almost half of all the patients in our local hospitals, Fairfax and Alexandria, have COVID. And they're doing a pretty good job working with those people. They're not maxed. They have extra room in their ICUs because they've expanded every ICU to be working in this particular way. What we see is that the numbers just kind of, the numbers of people in the hospital, and I think when we say, are they peaking, it means that the number of new patients per day is not escalating exponentially like it was in the beginning.
Right.
But it does mean that there's the same number of new patients again and again and again. And those people stay in the hospital sometimes for only a day or two. Actually, we've had patients with COVID who've been treated and discharged within 48 hours. But some stay for 3 weeks or 5 weeks. And so it's hopeful that we're reaching a plateau, I would say. I wouldn't call it the peak until we see it going back down. So I just am tremendously grateful for you guys all being at home, for staying at home, for going to the grocery store in a very strange way, for only talking to your neighbors out in the very airy outdoors, several feet away from each other, and hopefully by now, with all one of these, we really need you to continue doing that. We really, really don't want to overwhelm the hospitals. We're just at that point where every day when I look at the numbers, I'm hopeful that they will be staying the same, and they've been staying the same, but we aren't working down the other side of the slope yet. So that's the short story on how busy we are in the hospital.
Right. Yeah, we're still in the thick of this. So thank you for the visuals. Yeah. And as I mentioned, hot off the presses is this antibody test. Do you want to speak about the antibody test that exists right now and where we think we stand with that?
Well, I can speak to antibody testing in general, which is that we have a caution about it because although 90 companies applied to create antibody tests, and I believe the first round, 30 of them were approved, none of them have had time to be properly vetted, just like nothing has had time to be properly vetted in this COVID epidemic. The first reports were that some of these tests that were available were hopefully going to be 80 to 97% accurate. And in fact, when they were retested by independent organizations, the truth was that they were maybe only 30% accurate. And so I think what a company purports and what becomes true over time with repeated testing are probably two different things. Like Dr. Zweig said, we don't know the data on the test that has just become available to us, so we'll update you. I don't know any of the data on it yet. But we want to be careful because one coronavirus looks a little bit like another coronavirus. And so the risk is when we do an antibody test, we want to make sure that we're not accidentally picking up DNA from a cold you had in 1994 and saying, oh, look, this is protein just like this coronavirus from COVID-19. Because those proteins could be so similar that we're accidentally finding that you're immune, but it's to a similar disease, not the one we're looking for.
Sure. Well said. Yeah. So stay tuned.
I guess one more thing, Dr. Zweig, is a lot of my patients just need help understanding the difference between having antibodies and being immune.
Right.
And so I think let's say we had a test that was actually testing for this particular SARS-2 virus, this COVID-19 virus, it would say that we had been exposed to it, and we can be hopeful that that would confer some immunity, that having been exposed would confer immunity. Hopefully it will, but we won't be able to prove that you're virus-free by doing that antibody test. We're We're not able to prove that if you're exposed in December to the same virus that you'll be safe from it, and we don't know whether you're still contagious by that particular test.
And we don't know that even if you are immune now, that you'll be immune a year from now or 5 years from now. So we don't know how long, if it does confer immunity, how long that immunity will last.
Right.
A lot still to learn, but we're coming along.
Mm-hmm. Yeah.
This next question is actually may sound very simple to a lot of people, but it's actually a really important and much more complicated question. Again, even before COVID ever came around, it's a really important question to physicians and in medicine, and that is, what is shortness of breath?
Mm-hmm.
Can you speak to that, please?
Yes, I would love to talk about what is shortness of breath, because there are a few tips we could give you at home when your brain is racing and you're thinking, was that shortness of breath? I'm looking for this symptom. What does it feel like? So perhaps I could give a couple of demos of shortness of breath. Someone who comes in and has a really long conversation and is explaining and explaining and explaining and talking and talking and talking, and then they say, and they have a big sigh. That is a sigh. That is not shortness of breath. A lot of people, when they're overwhelmed, I actually was famous for this in the 9th grade. During my tests in French class, I would unconsciously, and everyone started mimicking me, and I didn't realize I was doing it. But that's just such a human, natural response to stress. So a beautiful, big clearing breath like that is a sigh, and that is not shortness of breath. If you can talk like I'm talking, where you're able to get out several sentences in a row, you're not even thinking about breathing while you're actually distracted, and you're having a fun conversation, you're not short of breath while sitting there. So then you can kind of take yourself out for a spin and challenge yourself, and you can say, well, I'm not short of breath while sitting here. What do I feel like when I walk up and down the hall? And what does that feel like compared to what it was in December when I walked up and down the hall? And for each of us, we have a baseline, and it's the change from that baseline that we're looking for. So some people who have any number of conditions could be somewhat breathless as a baseline, and they kind of know, okay, this is about how much I can do before my breathlessness catches up with me. For those who are pretty healthy, we should be able to walk up the stairs just the way we walked up the stairs in December. We should be able to go outside and take a walk. So when you're wondering if you have shortness of breath, take yourself out for a test ride. And whether that means you're just standing up from your chair and walking into the kitchen and back, great. Does that feel like it used to? Well, then you're okay. And then go as far as you can. I would suggest you go out and exercise, go out for a bike ride, take a walk up a big hill, push yourself and see what it feels like. And then when you have a good sense of what brings on what you're feeling, then call us and let's talk through it. But you can tell by looking at me and hearing my voice, even just on the phone, I'm not out of breath. And so a lot of people just need that coaching to understand what to look for.
Great. Yeah, that's a great description. Obviously this is a very anxious time for everybody. And the hard part is anxiety can create the urge to need to take that deep breath, which then people can interpret as shortness of breath, which makes them more anxious and just exacerbates the problem. Where really, it's more anxiety and just the need to take a deep breath rather than feeling like you just came back from a run or exercise. And so that's
if you're observing a person who's ill and you're watching them for shortness of breath, how much they can speak is a very helpful indicator. If you begin to notice how much people can speak, usually people can get a couple sentences out in one breath. And if you begin to realize that that's truncated, then you can kind of pay some closer attention. And if a person can only really get through a little bit of a history and then they're gasping for air, that obviously isn't right. And we would want to know about that right away and make sure we can help you decide what to do.
With that said, moving on to the next part is that, can you comment on silent hypoxia and the role of pulse oximeters?
Sure. So what's been brand new to the medical world in COVID is people who appear pretty well, and then there's kind of sitting and waiting in the emergency room, or they're kind of tolerating doing something at home, and they're actually pretty low on oxygen. And we don't fully understand that yet, because we don't fully understand anything about COVID yet. That could be related to blood clotting. It could be related to lung inflammation. It could be related to cardiac manifestations. But I think it's been surprising for many doctors treating lots of patients in the emergency room to see someone go from kind of walking in to needing emergency intervention in a pretty short order. So there is a phenomenon where people are low on oxygen and don't look as bad as we're used to seeing them look when their oxygens are low. But I think if you're at home wondering, is this me? You can still do that same test. I mean, you can still take yourself out for a spin, because those people, when they actually are putting demands on their body and they're trying to walk or trying to walk up a hill, they're not going to be able to do it. So that is a new phenomenon, and we're learning about it. There's lots of questions about pulse oximeters, and pulse oximeters are helpful in figuring out if how close is a person's oxygen to normal. And they are a big part of what's being done in the emergency room and what we do here in our office when we're testing somebody who has any kind of pulmonary problem. If you have COPD or asthma, or if you have anemia, or if you feel really crummy and your lungs sound what we call junky, if you have bronchitis or some kind of pneumonia, we're always looking at those pulse ox numbers, because they help us see the severity of the, it's one window into the severity of the situation. It would be nice if everybody could, just stick one on their finger all the time and know what their pulse ox is. But it would be nice if we all had, 16 rolls of toilet paper in the shelf too, and we just can't find that right now. So we do have some pulse oximeters at our office. I know Dr. Brauer has them at her office. And if you need that and you're not able to access it, I mean, I really don't think you'll be able to find one right now online, but if you order one, maybe it'll come in a month or so. Could still be useful for the next 2 years of wondering about this. So they're definitely playing a role. And it is, because it's so little and you can stick it on your finger at home, it is something that could be done at home. So it could become part of more monitoring. I don't think it's a very helpful way to diagnose what you have. It's more just a way of checking how well your heart and your lungs are pumping the oxygen through your system. And don't do it when your fingers are cold, because you'll wind up calling us in a panic. So, just stick your hands under your armpits and warm them up, and then try it.
And the same thing with nail polish too, which can also interfere with it.
Yes, good point.
Yeah. So, all right, great. That was very helpful. This is my favorite question, is the next question that we got. So it says that if heat kills the virus, should I get into my hot tub?
How about no matter what, should you get into your hot tub?
Sounds fabulous.
Yeah, Dr. Zweig and I thought neither of us have a hot tub, but we'd love to be getting into one. So we encourage whoever wrote that question to get into their hot tub. I haven't seen very many hot tubs with soap in them. I would just suggest that you wash. So take a shower and soap. So soap kills this virus. So just lather up, and it doesn't matter whether you have a hot tub or take a shower, wash your hands. Really during the day when most people are quarantined, really the only thing they're coming in contact with that could be dirty is on their hands. And then there's whatever we touched with our hands. So if you put on a fresh pair of clothes and took a shower and sudsed up and washed your hands really well, that should be quite sufficient. And also, I hope you enjoy your hot tub.
Right. That certainly should help stay-at-home orders.
Yeah, right.
And I think we touched upon this last week as well, but this is a good question that keeps coming up. How long does the virus last on different surfaces, and what does that mean?
Yeah. So like we told you last week, the science could evolve. I think right now we're still saying what we said last week, which is that we think that the virus lasts live on surfaces, hard surfaces like plastic and metal, for about 3 days. I think that could be situational, but I think that's what basically we're understanding. It probably lasts a shorter amount of time on clothing and on cardboard. So for example, if you were bringing home your, if you wanted to open your box of Triscuits, which I did last night, you know, I opened the box and then washed my hands. And what's inside the box is clean because no one's touched that for months. So if you're bringing in new groceries and you just let them sit for a couple of days, those containers probably won't have any more contamination. But hard surfaces like doorknobs, handles that you would touch in your car or on your toilet, those things are going to probably be able to harbor the virus for 3 days. Stay tuned, and maybe there'll be a new set of information next week.
Right. And yeah, we're still waiting to see what detecting the virus versus what is infectious is. And we don't quite have a good handle on that yet either. So like everything else, we'll stay tuned. And then one last question I think is applied. This is focused on asthma, but I think this really applies to just about any pulmonary disease. The question is, it's asthma and allergy season. How do we monitor these symptoms when you have asthma, allergy, or any other pulmonary condition? How do you distinguish that from COVID?
Mm-hmm. So the asthma data in the pulmonary COVID has been, at first was really concerning. We thought, oh, anyone with a pulmonary disease, we're going to have to be a little bit extra careful for them. And I think I would still hold that to be true because we just don't know that much. But I did read some data a couple days ago that was noticing that it wasn't mostly asthma that was listed alongside people who had actually died of COVID. That the challenging parts of the COVID virus have to do with inflammation, perhaps, and blood coagulation, and may not be directly correlated with whether or not a person has asthma. So how does a person monitor their asthma symptoms? This is something that we can really coach well on the telemedicine visits. And if you've had asthma for a while, you might be used to this. So you should have a sort of baseline level of physical capacity. And if that begins to become a little bit reduced from whatever your typical maximum capacity is, then we're going to wonder if your asthma is acting up. And also go with your own personal history on a year-to-year basis. If you've been in DC for a few years, then you know whether or not you have allergies to this pollen in this springtime. And if that pollen allergy bothers your asthma, it's been something that will resonate with you. Like, oh yeah, you know, every year around March or April, I wind up needing an extra inhaler. And so it's a good time to have that inhaler at home. And then again, same as what I was suggesting before, you know, take yourself out for a ride, take yourself around the block, walk up the hill, and judge what your symptoms are. If we can't tell whether your symptoms are only from asthma or only from allergies right away on the phone, but I think the management is going to be, the only difference about the management is that we're going to be paying more attention to what the progression is. Always in asthma, we want to know, is this getting worse? Is this a stable thing where the same type of activity bothers me on a day-to-day basis? Is it serious? Is it something that's making a person have trouble getting through a sentence? well, no matter what is causing that, we really want to know that right away and be able to address it with you. If it is a COVID related manifestation of the infection and it's causing something that's like wheezing, but a patient is able to walk around and is able to kind of go through their day and not be in a lot of distress with shortness of breath, we would still help you through that at home most of the time. But Dr. Brauer was saying on the phone yesterday when we were discussing what to do in certain cases, she said, well, it depends. So I think your situation is unique, and that's why we really want to address it individually with you. And we want to really think through all of the possible permutations about what could be going on for you. So please call us and let's figure it out together.
I wanted to ask one more question that actually didn't come in, but I think is a really important one, and probably people are wondering. We talked about it last week, and Dr. Brauer alluded to it as well. People who are on medications that might make them nervous, such as ACE inhibitors or angiotensin receptor blockers that we're seeing in the news, or immunosuppressants, things like those. If there is something that makes you nervous, what should patients do about those medications?
So absolutely call us and let's talk it through. Like Dr. Brauer said, it's really important to stay on medications for inflammatory bowel disease. It's really important to stay on a lot of arthritic medications, but we can be careful about what we choose, and we can think about whether or not there are any alternatives. What we really want to do is be able to work with you together and figure it out in each individual case. I think I just talked to someone who had just stopped all of his medicines for a month, and his complaint was he couldn't get in touch with a certain person, the person who was prescribing it. And I don't know how hard he tried, but I was able to get in touch with that person. So we were able to kind of triangulate for you sometimes with other physicians if you need that help, and make those decisions together.
And with that said, I think it's a good thing to reiterate too, that what you read in the news may make for good news, but not necessarily good medicine. Things like the hydroxychloroquine, we're still wondering about that. The ACE inhibitors and angiotensin receptor blockers got some initial bad press, but recently there was another study that said actually they may be protective. And so we're still waiting for more information. You don't want to just react from a gut instinct on these, because we just don't know enough. And so if you're on a medication that was deemed necessary before COVID, it's probably still necessary after COVID. So please continue with that, or at least call us and discuss it before you stop anything. Great. All right. Well, that was very helpful. That's pretty much all we have for today as far as COVID-related things. But Dr. Beauvais, can you talk about our pending move and when the date is and what we expect from that?
We're closer to the date. I feel like I can almost tell you, but I'm not quite there yet. But we'll be mid-May. We will be moving even in the midst of this crazy time, because we were still getting kicked out even in the midst of this crazy time. So please stay posted. We won't be able to host you in person in a warm open house, but I'm sure we'll be able to send pictures, give you maybe a virtual walkthrough. And it would be a great time to do a telemedicine visit and get to see the office.
Hopefully do a virtual tour and virtual happy hour at some point.
Right, right.
Great. All right. Well, thank you, both of you. That was very helpful and very well spoken. I hope it was helpful to everybody at home as well. So in summary, a couple of things just to close out. I just wanted to say, obviously, I think we've driven home the point in that communication is really the key. And that's nothing new. That's in medicine in general. We want to communicate. We want to hear from you. Please call us. Please make an appointment. Please keep in touch with us. That's why we're doing these town halls. We have the time, we are available, and we want to hear from you. So please don't hesitate to reach out. And if you're not sure what to do, we can help you with that. You're hearing a lot of we don't knows, we don't knows. Part of that is that, one, there's a lot of information still coming out, but also because it's dependent on each individual and each case is different. And so by speaking with us as an individual, we can help you weigh the risks and benefits and decide what the best approach is in any situation. So please, please reach out to us. Right? And then on other points, just as we said, NVFPA is doing as much as we can to help with this. Our telemedicine visits have been really working well for us. We are available. We're doing them every day, and they work quite well. We're doing these town halls. We're trying to write blogs, do podcasts, everything we can do to help reach out to you, get the word out, and educate you as best we can. So please check our website to see what we're doing, see what we're doing next, and to stay in touch with us as much as possible. Also, keep in mind that we are doing this again next week. I don't know if we've figured out the time yet. I think we're going to wait on that, but please be aware that we are probably going to do one on Thursday. Do we have
it's Friday at noon.
Oh, Friday at noon. I'm sorry.
Yeah. So Friday at noon, a little plug is we're going to be having Dr. Cecily Havert will be hosting a psychologist and a psychiatrist. I'll hold off on introducing their names, but I believe we're allowed to, but I'll wait on that since I didn't confirm. And we would love to have you join us. It'll just be a single session at noon on Friday. That's May 1st.
I hope you all can make it for that.
Mm-hmm.
All right, well, thank you all again for your participation and for staying involved with this. Please continue to send in questions and we'll try to answer them as best we can on these town halls or in other ways. Thank you, Dr. Brauer, and thank you, Dr. Beauvais. That was really helpful. I think that went very well. And we are, if you're interested, doing this again at 7 p.m. tonight, so feel free to tune in for that one as well. Thank you, everybody, and hope you have a great day. Stay safe.